Hello friends, today we are going to discuss here about NEET PG MCQs from 6 to 10th number. MCQ 1 to 5 I already discussed. Let's start. 50-year-old male with Crohn's disease of ileum had intestinal obstruction. He underwent resection and anastomosis of ileum. 10 days later, he arrived in ER with 1 liter bilious leak from the drain. He is managed with antibiotics, TP and total parenteral nutrition and nil per oral regimen. 4 days later, his ABG pH is 7.24, means in acidosis patient. Partial pressure of oxygen is 98, PCO2 is 40 and anion gap of 10. What is most likely cause of this ABG? All 4 options in front of you. If you want, you can pause this video and try to answer in comment section. Now I am going to make this very easy for you. Let's see all questions. So, what is the single best answer here? Guys, this is not a case of renal failure. This is not a case of diabetic ketoacidosis. This is not a hypovolemia. This is an exact cause of small bowel fistula. This patient has a high output fistula with normal anion gap 10 to 15. The patient has metabolic acidosis with normal anion gap, which happens with loss of bicarbonates due to pancreatic fistula, diarrhea, small bowel fistula or gain of chloride, excessive saline infusion. Which of the following is not associated with peptic ulcer disease? Very high yield MCQ for exam point of view. Zollinger-Ellison syndrome, primary hyperparathyroidism, cirrhosis or pernicious anemia. Which condition is not associated with peptic ulcer? Zollinger-Ellison syndrome is associated with peptic ulcer, primary hyperparathyroidism 2 and cirrhosis, but pernicious anemia is not associated. So this is the single best answer. Let's discuss all the condition which is associated with peptic ulcer. Pernicious anemia has achlorhydria, in which the chances of ulcer formation are rare. Peptic ulcer is associated with a host of conditions. It includes infections like H. pylori associated ulcer, HSV, CMV cytomegalovirus, herpes simplex virus, helicobacter, pneumonia, other rare infections like TB, syphilis, mucormycosis, etc. And some hormonal or mediator induced, including acid hypersecretory states, gastrinoma, systemic mastocytosis, basophilia in myeloproliferative disease, antral G cell hyperfunction, existence independent of H. pylori is detectable. Drug exposures like NSAIDs, aspirins, including low dose aspirin, bisphosphonates probably when combined with NSAIDs, clopidogrel when combined with NSAIDs or high risk subjects. Corticosteroids, steroids itself causes ulcer when combined with NSAIDs. Okay. Now, some other drugs like sirolimus, spironolactone, probable no data with NSAIDs, co-therapy, MMF like mycophenolate, mofetil, potassium chloride, chemotherapy, example hepatic infusion with 5-fluorouracil, post-surgical like antral exclusion, post-gastric bypass, mechanical duodenal obstructions, radiation therapy, infiltrating disease, sarcoidosis, Crohn's disease, ulcers, stress intensive care unit ulcer, cirrhosis, organ transplantation, sarcoidosis, Crohn's. Okay, so many associated with ulcer, peptic ulcer. Now, which of the following is associated with metabolic alkalosis? Gain in fixed acid, loss of base, rise in base excess, hyperkalemia. So which is associated with metabolic alkalosis? If you want, you can pause this video. If you want, you can think, you can take your time, but try to answer as soon as possible. So answer is rise in base excess. Increase in base excess is associated with metabolic alkalosis. Metabolic alkalosis is associated with loss of fixed acid and hypokalemia. Classical example is vomiting in pyloric stenosis. Guys, in exam, they like to ask, when patient is pyloric stenosis, recurrent vomiting, which electrolyte abnormality you find? Hypokalemia, hyperkalemia, Okay, hypokalemia. Now, true about reactionary hemorrhage after cholecystectomy. Very good in MCQ. Lot of probability to receive in exam. It commonly occurs within 24 hours after surgery. It is caused due to infection, mostly because of slugging of tissue. It is more common than primary hemorrhage. What is true about reactionary hemorrhage? Very important. Very important. So what is single best answer here? If you want to think, if you want to have some time, then you can pause this video and try to answer. Best answer is, it is commonly occurs within 24 hours after surgery. So what is reactionary hemorrhage is less common than primary hemorrhage and is most commonly due to dislodgement of clot or over aggressive resuscitation. It is not due to infections. It can be due to slippage of knots or sutures. Most of the times re-exploration has we carry out. Secondary hemorrhage is due to infection, pressure, necrosis or malignancy. Secondary hemorrhage is due to infections, pressure, necrosis or malignancy. But reactionary hemorrhage is less common and than primary hemorrhage, and it is commonly due to dislodgement of clot or aggressive resuscitation, not due to infection. Now our 10th MCQ. Which of the following patients of appendicitis do not have increased risk of perforation? Excellent MCQ. Children's patient on tacrolimus, obese, pelvic position of appendix do not have risk of perforation. So best answer here is think before answering. Think. Answer is obese. Some group of patients have increased risk of perforation of appendix. These groups includes extremes of age, patient on immunosuppressions, pelvic appendicitis, fecalith obstruction, diabetes mellitus. Hope guys this video is clear. In exam the NEET PG MCQs is like this. Okay, and if you like this video then put like on it, and if you want to do preparation in a very short duration and if you want to crack NEET PG exam, then I have one subscription program where I provide you 8 subject, each subject 100 one-liners, total 800 one-liners for short subject, because in exam short subject MCQs they like to ask directly, and 600 recorded videos, all 19 subject are including. The total fee of that program is 5,000 only. And how to join this program, how to take subscription of that program, details available in description of this video. So guys, thank you.